We're now going to bring up our Smith-Lemli-Opitz Foundation Medical and Scientific Advisory Board. And these are folks upon whom the foundation depends heavily to provide the guidance that is needed to best support all of the families. So I'm going to ask you all to come on up here and introduce yourselves, and then we'll ask you some questions and hear what sort of conversation ensues. Dr. Rizzo, do you want to come up here first? And if you could, when you introduce yourself, tell us who you are, what your specialties are, where you're located, and then how and under what capacity you've been serving the families who are affected by SLO.
Thank you. Thank you. Yeah, I'm Bill Rizzo. I'm a pediatrician and a geneticist at the University of Nebraska Medical Center in Omaha. So I see patients with metabolic diseases of all types. Smith-Lemli-Opitz is one type that I'm interested in particularly. Okay. Maybe I'll start over. Huh? Yeah, my name is Bill Rizzo. I'm a pediatrician and a geneticist who sees patients with metabolic diseases. And I'm located at University of Nebraska Medical Center in Omaha, Nebraska. And we follow some patients with SLOS as well, of course. And I'm very interested in clinical research along with laboratory research, so I do laboratory studies as well as clinical studies. I've been involved with the foundation, maybe 6 years, maybe, something like that. And I'm happy to see patients in Omaha with SLOS. And I bring kind of a newer experience, let's say. I don't have the long experience of Dr. Porter or Dr. Elias. I mean, they're the experts really on this disease. And from a clinical point of view, particularly, you can't beat someone who's had 40 years experience with SLOS. I've had 40 years experience with pediatrics and metabolic diseases, but not with SLOS. So I will depend upon those two to answer many of your questions because they're the experts. That's why they're here. Happy to take any questions you have at this point in time, but maybe we should wait until we introduce the whole board.
Thank you so much, Dr. Rizzo. Who am I inviting up next? Dr. Porter, I see you're here. Do you want to stand up and remind us who you are?
Sure. So, Denny Porter. Denny's a nickname, but I go by it. You actually put it on my name tag, so professionally I go by Forbes. Anyway, I'm a pediatrician and a clinical geneticist. My interest is, I'm at the National Institutes of Health in Bethesda, Maryland, as was mentioned earlier. I have a split both basic science research group and a clinical science research group. My goal is to study disorders, rare genetic disorders. How do we translate findings from the laboratory to the patients? Have been studying Smith-Lemli-Opitz syndrome since 1998. Basically started my research group with Smith-Lemli-Opitz syndrome. So we do everything from the mouse to cell culture to the individuals with SLOS. Also work on other rare diseases, one of them called Niemann-Pick disease type C. They actually have too much cholesterol in the wrong spot. Very different disease in that they lose their neurons and actually die of the disease prematurely. So that's sort of my background. from clinical science and basic science and trying to figure out how to put it together to help these kids.
Thank you so much, Dr. Porter. Who else am I calling up here? People are just like, ping-ponging me back and forth here. I'm happy to do it. Let's see what Gretchen's about to say.
We're going to set up chairs, and if you're a SLOS specialist, this is the time that you would come up. We're going to have you introduce yourselves. And then this is the time that if there are questions, and Neil, you might be busy on this one, because if there are questions that weren't able to get asked and answered, we're going to have all of them come up. Nope, bring them over here. Yes. Or there. Great. So so this would be Dr. Elias, Dr. Haas, Dr. Porter, Dr. Rizzo, JB, Dr. Hall, anybody who presented for us or who has a specialty in SLO, please join us at this time for the panel. These panels actually used to be about 4 hours at the conferences long ago, and because we've done such a great job at beefing up all of the sessions, we've been able to kind of make it shorter, but I want to acknowledge all of these researchers and scientists and medical professionals, not only for their work into Smith-Lemli-Opitz and related fields, but also to acknowledge the fact that when we have a question that our families, they talk a lot and support each other in the Facebook support group and our other carrier physician parent support group. If there are things that we can't easily reference for each other, we go to our medical advisory board and triage the questions with them. Dr. O'Connor, come on up. There you go, come on up. Your session isn't until later today, but when you introduce yourself, you're gonna probably be one of the most popular ones up there, so. So please feel free to pepper them with general questions, individual questions, because these are the people that answer our questions and your questions when we can't find answers, because the Smith-Lemli-Opitz Foundation, we cannot give medical advice. We are there for everyone all around the world. And so when there is a medical issue, these are the folks that we turn to. And I want to acknowledge their work on the board, including some that aren't here as well. But please give them a round of applause, and then I'll let them introduce themselves. We're going to start with our chair of the board. This is JB Roulet. I'm going to let you introduce yourself, and you can just go briefly, and then we're going to start peppering.
All right. So second time I introduce myself. I'm JB Roulet. I worked at OHSU for some years with Dr. Steiner. That's where I was introduced to the Smith-Lemli-Opitz syndrome clinical research and bench research. If you have clinical questions, don't ask me. I cannot tell you anything about anything else other than research questions. So the clinicians are to my right, and the other right ones. Yeah. So. But if you have clinical questions, I focused on stem cells. I focused on clogged genes and sleep abnormalities in cellular models. I focused on dietary intake, cholesterol pool, and anyway, a long list of things. So don't ask me any clinical questions. Thank you.
So, hello everybody. I'm Dorothea Haas. I'm a pediatrician and I take care of patients with all kinds of metabolic disorders, but I'm especially interested in patients with Smith-Lemli-Opitz syndrome. And I'm based in Germany, in Heidelberg, at the University Children's Hospital. And well, I see quite a lot of SLO patients, and I would be happy to take your questions.
You know me. Hi again, everyone. I'm Samar Rahal. I'm working with Dr. Porter in Bethesda, Maryland on the SLOS Natural History Protocol. We met yesterday. I'm a pediatrician specialized in endocrinology.
Hi, I'm Julie O'Connor. I'm a licensed psychologist, and my area is to work with individuals with severe behavior problems who also have neurodevelopmental disabilities. So I actually was started knowing more about SLO back in like 2005 with Dr. Tierney, and then 2007, I think I was at the conference then too. But over the years, I've been working with a lot of different syndromes and disorders that do have a combination of metabolic or genetic disorders, as well as having severe behaviors such as self-injury, aggression, property destruction, you name it. Those are my kids. So I've been doing this for about the severe behavior for 30 years as of July 1. So it's been a little bit of time. So I have a little bit of knowledge about how to treat and assess behaviors. So happy to help you. And I'm at Kennedy Krieger Institute in Johns Hopkins with Dr. Tierney, who is on her way.
And now we're curious to know what questions you all have for our esteemed panel.
What are the current studies that you're having besides the natural history study that we know about that we could possibly come and visit? It would be nice to go to Germany. Is there a way that we can get funded to travel there for a study?
Okay, we do have a natural history study as well, but right now it's limited to European patients, unfortunately. But yeah, we are happy to connect, and I think it would be a great idea to, share data.
So my antioxidant study is still ongoing, and we have been having conversations about starting a colic acid study in the future, so stay tuned for that. Dr. Tierney's on her way down, and she can tell you about her study.
Go ahead.
Hi. Our biggest issue right now is, I'm sure with a lot of kids, is the frequency and prolonged illnesses that we're experiencing. I know that a lot of the factors come into play around COVID, not being exposed to germs and stuff like that, but I know as soon as she gets one tiny little germ, she's at least out for a solid week. Is there anything that we can do proactively during that we can even lessen the amount of time that she's out? I wrote down the stress steroids, but I think that was just for fevers potentially. But if there's anything else, I would love to hear it.
So the stress, how old is your child?
She's 6.
6 years. So, kids that age who are going to school tend to get a lot of infections because kids pass them around all the time. Yeah. So part of getting a lot of infections is just being that age and being in school. Yeah. Where you want her to be, by the way. But the problem is how you tolerate those infections and so on. The stress steroids, not everybody needs them. They are really reserved for patients who have very severe disease, who have very low cholesterol levels, and so they're not able to make the adrenaline, the cortisol, that is your body's normal response to very severe stress. So severe stress might be a high fever or what we call sepsis, where you have an overwhelming infection. So I have treated patients with Smith-Lemli-Opitz who don't normally have such a low cholesterol, but if they've been in the hospital with sepsis and very severe disease, then their cholesterol level can drop and they might not be able to make enough cortisol. So in that case, I have given stress steroids to patients during that kind of severe illness. Also major surgeries. If a child has a heart disease and they're having heart surgery, or some kind of a scoliosis repair or something like that, a big surgery that takes a long time, I'll often think about stress steroids in that situation. But otherwise, steroids are not generally needed. And then in terms of keeping your child as healthy as possible, I often encourage parents to be in good communication with their school. So, I've written many, many letters for my patients saying, this child has medical fragility, they get, really, really sick if something's going around, that the school should, often the schools will send out a letter to everybody in the class saying, we have a medically fragile child in our class. If your child is sick, keep them home, right? And that sometimes parents don't think about that. If their kid just has a little cold, they'll send them to school anyway. But if they get a letter like that in the beginning of the year, they're more likely to be a little bit more careful about that.
Thank you.
Thank you for that question. Other questions in the room? I think we've got a question online.
Not ready. Someone else asked a question here.
We've got one over here. We've got two over here.
I'll bring it to you next.
My background is neonatal ICU, and I'm just curious if many neonatal physicians and nurse practitioners, do you feel that they know about this, or is it something that takes a while for them to research and figure out?
So in lots of different hospitals, if a baby is born with multiple congenital anomalies, they'll call a genetics consult, and that consult will come up and see the baby in the NICU and recommend testing to do to try to make a diagnosis. So that's probably the best way, because it's hard to teach all neonatologists what this with Smith-Lemli-Opitz is, but it's pretty easy for them to call a genetics consult.
Okay, thank you.
Any other thoughts about that?
It's unfortunate that a lot of the neonatologists are not trained to recognize these kinds of diseases. And depending on the severity of the baby, as far as the malformations, they may not make that diagnosis. And kids get discharged without a diagnosis, as you all know. I had the experience of diagnosing SLOS in a 50-year-old woman who had never been diagnosed. So these things happen. I think a lot of the failure to make a diagnosis is simply not thinking about the diagnosis of SLOS, and a lot of the people don't know that disease, I'll just tell you that. Even the pediatricians that see these kids later on don't recognize it oftentimes. And like every other genetic disease, there's variation in severity. So some patients will have a few of the features, but not all of the features, and they slip through the diagnostic attempts.
I thought we'd take a moment to ask Dr. Tierney to reintroduce herself.
Hi, I'm Elaine Tierney. I'm a pediatric psychiatrist at Kennedy Krieger and at Hopkins.
And folks have talked about how long they've been working with SLO.
I guess for about 23 years.
The other question had been about any research studies you're doing.
Research studies. So I'm looking at behavioral aspects of Smith-Lemli-Opitz, and then I do the cholesterol and autism studies that are kind of related to SLO.
Thank you. Question over here. Thank you.
Yeah, I'm asking you guys to kind of look into the future. We have a 15-year-old daughter. I know we're talking about trying to penetrate that blood-brain barrier, stem cells into the brain, getting the brain to make its own cholesterol again. So she's 15. What would be the theorized benefits or outcomes that we could possibly see? And then really, how close are we?
Okay, so, with Smith-Lemli-Opitz syndrome, I think there are two components, and I don't know how severe your daughter is. Moderate. There's a component that's related to development, and that's not going to be fixable in my mind. There probably is a component that is functional, that at the ends of the nerves where they communicate with each other, cholesterol is important, and my guess is if you can modulate that biochemistry, that you have the potential of having a positive therapeutic effect. So I think it's going to vary across this. You all know it's a huge spectrum. I think there's a better chance of having more of an impact the milder a patient is compared to the more severe patients where we know there's developmental issues that we don't have the ability to try to address right now. And did you have a second part of your? Here you go.
And how close do you think you are to getting past that blood-brain barrier?
How close? SLOS is not the only disease where the blood-brain barrier is a big issue. You know, and I use the analogy, a clock. I see the science moving forward. My clock's going like this. Parents see their child. Your clock's doing this. So it's a perspective. Are we close? I don't know. I do know there's a lot of technologies being worked on to try to solve the issue of the blood-brain barrier because it impacts not only Smith-Lemli-Opitz syndrome, but a lot of these other inborn errors where we're trying to get proteins across. You know, gene therapy holds a lot of promise. We can make it work in the mouse. I think you can make any gene therapy work in the mouse. You got a tiny brain, human brain. It's a scaling problem. People are working on it, trying to get the efficiency up, et cetera. So, you know, when you ask me how close, I don't know because where's that next scientific breakthrough going to come from? But I can tell you there are a lot of people working on these problems, and when it's solved for one, it will apply to other diseases, including applying to SLOS.
Part of that asking is our son is a carrier. He's only 11 now, but we're hoping that a lot of changes will be made by the time he's ready to have kids, and we could avoid all of this mess when he wants to have children.
Yeah, so, you know, it's an autosomal recessive disorder. It's unlikely that you ever saw it in your family. And that's because him being a carrier, his partner has to be a carrier also, okay? And that's a low probability. And you guys are going, low probability, what do you mean? We have kids with SLOS.
Yeah, right?
You know, but realistically, there's a whole set of other disorders. We're all carriers of these detrimental genes. We don't understand why they've been in our families, generations. You know, what I recommend, the technology is getting better and better. When your son is ready to consider having children, he needs to get with a geneticist or a genetic counselor. What is the technology that exists at that time? Right. And so they can talk him through the testing. Because it's not just SLOS. That actually drops off fairly low because of the rarity. But, you know, there's a whole group of genetic disorders that they might want to talk about.
Hi. Say, I'm wondering, just, you know, based on a lot of the conversations that have happened on the support group, why does the progression of an illness often go so quickly and get so critical for our children so fast, especially respiratory disorders like an RSV or a pneumonia or, and the like with our children? And are there ways we can identify the warning signs of trouble and what we need to tell physicians, emergency room professionals who maybe don't know our kids? You know, or when is it appropriate to have them consult with an SLOS specialist? Is it before a surgery? Is it a critical illness? When is it appropriate for them to connect with you all, when we're in crisis?
Yeah. And I'll talk about it a little bit. And the big question is why? We all know it happens. We've all had it happen to us. I get the call, a week later, minor cold, and then the child has died. We've known about this since early on. It's occurred. We don't know why. Very few cases have we caught to where we can get some information about what may be going on. I think, at this point, and I'll address, how I think we need to try to understand that why. But I think at this point, what I tell families is, if your child is getting sick to the point that you are thinking about a hospitalization, or even close to that point, tell those physicians to reach out and call us, okay? You can talk till you're blue in the face, and they're going, I don't know whether these parents know what they're talking about or not. You do, but, but get them to reach out and contact us. We had it last week, 2 weeks ago. It was, and luckily that child did fine, but it was reach out. If it's a major surgery, plan, reach out. I talk to the anesthesiologist all the time. The topic of stress steroids. Maybe use them, maybe not, but understand the biology of this disease, that if it starts looking like you need it, use them right away. Don't sit there and wonder about what's going on. So the best advice I can give is something major happening, have the physicians reach out, because we can talk them through what our experiences is, whether it's anecdotal, whether we have evidence for it or whatnot, but we can usually get them to understand the biology and the rationale of what we are recommending to them.
So what we do with our patients, we issue an emergency card, just a small card, which is red, so that everybody sees it's important. And you can show it to your doctor when you come to your local hospital. And there's our number on it, and there are the major points concerning Smith-Lemli-Opitz syndrome, steroids, and also that it may be necessary to apply for frozen plasma if cholesterol application is not possible. So this is a good thing, because then you don't have to explain anything. You just hand out the card. There's the number on it, and they may contact us.
That sounds like a great idea, that card. I have to think about that. What we do is we give families letters. This child has this diagnosis in the event of a severe illness or pending surgery. Please, think about these things, and then we have our phone number to reach on the bottom. We also, most people are seen in health systems that have electronic medical records. In my hospital, we use something called Epic, and parents can communicate in MyChart. And these electronic records talk to each other, so I can look in and I can see when my patient has been seen in multiple hospitals across the country, and it makes it easier to communicate with other hospitals. When patients come into the hospital, we have something called an FYI, which is a message that comes right up on the screen as soon as that patient is being seen anywhere. And for my patients with SLO, it says, FYI, this patient has this diagnosis, for severe illnesses or surgical interventions. This child requires stress steroids. And often the endocrinologist, the hormone specialist, has put in a dose in that FYI, so the doctors don't even have to call or calculate. They just can order it.
I also want to add that, you know, one of the hardest things is to decide whether to take your child in, right? You're sitting at home and you're like, oh, they're not looking so great, but I'm not sure it's worth an ER visit or, you know, a doctor's visit. And I think in this case, trust yourselves. Always we learn as pediatricians that, you know, we trust the parents because you know your child's baseline, and especially knowing what we know about SLOS and the fact that, you know, reserve is low in many cases and deterioration can happen rapidly. So with this example that Dr. Porter just gave with the patient last week, the first thing the mom said to me is like, I'm so glad I took him in. So in this case, I think, you know, better safe than sorry. It's not wrong to, you know, trust your instincts on that one. And then once you're in, then, you know, we can implement communication and all that.
Great. I think that, go ahead.
One more comment. There's some parts of the country where you can register your child into a program where they make that information and contact information available whenever they go to the emergency room for any visit. Called Project Adam. I don't know if it's available. I know it is in the Midwest. I don't know if it is available out here, for example, or on the East Coast. But I think that's going to kind of expand over time. So at least, you know, bring the child into the ER. At least they know what the diagnosis is and have contact information.
Great. Thank you so much. We've got a copy of one of the cards that, it's in German though. So, but on.
Well, it should be
Yep.
bilingual. So,
This one's just in
oh, then it's an old one.
this one's just in German.
Okay.
But what a great idea. You know, already I'm you know, I've got all sorts of ideas, but maybe this is something that the foundation, along with our medical advisory board, could put together, have a copy of it on the website. People could create it, laminate it. I know for us, we when Marky was small, we had we were right across the top in highlighted letters. If he would ever go in for surgery, if he ever have a major illness, you know, these people need to be contacted. And we had it right in his chart. But I love the idea of this, and we'll put this on the list of things to help to develop, along with looking at that Project Adam. And I think this is a really good conversation that we can, as a foundation, start to look in and make sure that we have this tool available to our families. And so thank you very much. This was a great start to a bigger conversation.
So Dr. Elias, is that the EPIC, oh, over here, the guy with the red shirt. Right over here.
Oh,
So with that EPIC, do the patients, their families have to sign a release at your facility, or how does that information get shared? And then does NIH have EPIC also? No? Okay.
So when a patient is followed, they are they connect with what's called MyChart, and that is a way that the patient can send questions, communicate with the doctor, see all the lab values that the child has had, and things like that. What I can do as a physician on the other end, if my patient lives elsewhere in another state, whatever, and that hospital where the patient lives is also in EPIC, I go into a program called Care Everywhere, and I can see all the records of all the tests and everything that happened to the child in that other hospital, because this particular electronic health record is carried by multiple hospitals around the U.S.
Yeah, very good. Thank you.
I use Epic as well. The parents have to, ahead of time, it's helpful the parents state that you can click off an Epic that your records are going to be available to other hospitals. When I go into Epic, occasionally that hasn't happened. I have to print the consent form and have the parents sign it at that time.
Very good. Thank you.
Several questions online now.
Great,
If
let's
I
hear them.
Can take a few seconds. First question is coming up. What do you know about aging in SLOS, and in particular, what does this look like for their mental health and changes in behavior from teenager years to midlife?
For the changes in mental health, I do seem to see some changes over the age. over the years. When individuals are younger, if they're on the milder side, they have quite a bit of ADHD, usually attention deficit hyperactivity disorder symptoms. Those tend to lessen, at least the overactivity part, as you get a little bit older. Teen years in general, in children who are typically developing as well as individuals with SLO, yes, it can be more a difficult time for volatility of mood and behavior. A lot of it is, we see in SLO is age appropriate, right? You want more independence as you get older, so there's more oppositionality, more difficulties, maybe some more swinging in mood, particularly around the time of puberty. It does seem to be that there's maybe more obsessive compulsive behavior in teens and going into when they're adults.
Okay, thank you. Another one for Dr. Tierney. Have you ever recommended Invega Sustenna injections for persons with SLO for extreme behaviors? We have seen marked improvements in our 35-year-old son for 8 months following these monthly injections. It is possible that he has dual diagnoses, but worth noting marked improvement.
Okay, so Invega is an antipsychotic. I haven't used that. I haven't used that myself. But as for, I'll address the dual diagnoses and then the meds again. So yes, so individuals with SLO can still have other diagnoses such as attention deficit hyperactivity disorder. They can have bipolar disorder. Invega is used for that. We do in individuals use injections in general in psychiatry if it's difficult for them to take medications by mouth to get them to take medications by mouth and to keep kind of a smoother drug delivery because it's in your system and coming out every day.
Thank you. Another question is, in respect of SIB, many SLO children start on a variety of medications. Do these behaviors subside with age so drugs can be reduced or even weaned off?
Okay, so the question was about self-injurious behavior. So with self-injurious behavior, we try to do a dual combination with behavioral treatment, with Dr. O'Connor we'll talk about today. We try to determine what the function of the self-injury is. Sometimes it's communication. Sometimes it's for attention. I work full time on an inpatient unit for individuals who have severe self-injury, aggression, and disruptive behavior. So we and most of the individuals we use a combination of behavioral techniques and medications. So, so the question about as someone's getting older, often I think that the self-injury tends to lessen, but perhaps that's because over time we're able to have a behavioral technique and find what medications might help in combination with it.
Thank you. Next questions. If we are currently on Colic Acid, will we be able to participate in the future possible study?
So we are just at the very beginning of planning what that study is going to look like, right? And we haven't thought yet about inclusion criteria and how we're going to do it. So stay tuned.
Yeah, it's probably not going to be possible if you're taking Colic Acid to start a new study on Colic Acid. There may be, when we decide what to do exactly, there may be let's say, an interval where you can stop the Colic Acid and then get enrolled in the study. So we'll talk about this when we actually have our plans a little bit more fixed at this point, but we don't really have that at this time.
There's about another dozen questions, so anyone in the room interject if you have any other questions as well too. I'll keep going until that point. Okay, and then Gretchen has a long one at the end.
It's short.
Our son has MRSA in his system since an infection when an infant. Is this common in SLOS?
Just being passed around.
MRSA stands for meth-resistant Staph aureus. It's a kind of staph infection, and it's not unique to Smith-Lemli-Opitz. It's very, very common in the general population, and we all have bacteria on our skin, and most of the time you don't have any problems with all this bacteria. Many of us in this room may even carry MRSA. It's only when you get a skin infection that gets worse that it can cause more of a problem because it's resistant to the usual antibiotics that one might treat a skin infection with, and so you have to use stronger antibiotics, some of which might have to be given IV instead of orally, and that's what can make MRSA be more complicated. So there are, some medications that you can use as ointments that would treat a mild MRSA infection, something called Bactroban, that I use quite a lot of. But in most people, it's not a severe problem all the time.
Well, the problem is it's more common in children who are often in hospital, who are often hospitalized, because you may acquire it from hospital because antibiotics are used and they select those bacteria. So, but it's not unique, as Dr. Elias said, to patients with Smith-Lemli-Opitz syndrome.
Hi, so our daughter is 21 months old, and we've just been invited to COVID vaccine. Would you recommend give it to her? She had COVID already, and she fought it on her own. She didn't need any hospitalization or anything. Yes?
Yes. Please.
Thank you.
Next question from online.
Okay.
Is are individuals with SLOS biologically capable of having children, and what are the risks of doing so? Can't hear you.
And the sound. Can you turn up the mic?
Check, check.
Okay, thank you. We had a young lady who was diagnosed after her two children had Smith-Lemli-Opitz syndrome, and she had Smith-Lemli-Opitz syndrome as well. So she was really very mildly symptomatic. She had just a little bit reduced intelligence, but no other symptoms of Smith-Lemli-Opitz syndrome. And, well, she didn't know that she had it until she was diagnosed with her children. But even other patients with Smith-Lemli-Opitz syndrome, they are fertile. So be aware that you get a good contraception in your teenage daughters because they may get pregnant.
Yeah, we had a young woman who actually was a special eds teacher. And I guess her obstetrician noticed 2-3 tosendactyly and decided to test, and had a very low 70 hydrocholesterol level. She had one defined mutation, one that we didn't totally understand. I sort of said, She's probably a carrier. It's probably the stress of pregnancy because your cholesterol level's supposed to go up as a pregnant woman. We're just seeing a higher level because she's a heterozygote. Let's test her after the baby's born. She has SLOS. So definitely you need to be concerned about young ladies and young men who may not be quite as inhibited.
So one of the hats that I wear in the American Academy of Pediatrics is thinking about sexuality in people with disabilities. And this question brings that up in my mind. So a couple of things that I'm actually going to be talking about that in October in Washington. They asked me to talk about it. So there are a couple of things that this brings up. One of them is HPV vaccine. So I strongly recommend it for all of my patients. Even if you have a child who's fairly mild and is going to be, going to high school, to a transition program, maybe in a community program, there are plenty of opportunities where that child is not going to be under your watchful eye all the time, and plenty of opportunities for possible sexual activity with young adults. And so getting HPV vaccinated is really strongly indicated for patients. And sadly, even patients with more severe problems who you would never think that they would be sexually active intentionally. There's a higher incidence of sexual abuse, very sadly, in our society in patients with disabilities. And so to protect those children, we talk about giving them HPV as well, and that's given in your early preteen and teenage years. So the other thing that I talk about a lot with my mothers of female patients is menstrual suppression. Once you get your period, it can really impact a person's ability to be self-sufficient and have good hygiene and be independent. So a lot of times we talk about menstrual suppression for our female patients, and there are many, many, many options to do that these days that are pretty safe. And I work with the adolescent GYN clinic a lot to help my patients think about those things. And then lastly, teaching about appropriate behaviors. A lot of times you'll have a child who might cognitively act more like a much younger person, is very friendly and outgoing, and might not understand the sort of usual barriers of interacting with other patients or other kids their age. And so it's really important to teach those patients the same way you've taught them everything else as a parent, right? You've taught them how to get dressed, you've taught them how to feed themselves. You can also teach kids how to have sort of more appropriate behaviors. So it's fine if you masturbate, and a lot of my patients do that, and it's a pretty normal behavior if you're a preschool age person, just normally. But if you're doing that when you're 16 and you're more pubertally mature, it gets you in big trouble if you do that at church or at school. So you can teach children appropriate behaviors, and it should be built into their school curriculum, when they're in junior high and high school, so that kids learn how to not get themselves in trouble behaviorally as best as you can.
Yeah, I'll double emphasize try to teach the proper behavior. I mean, we've had, the tolerance in schools is very low for inappropriate behavior, and, we've had boys get in trouble and expelled, and it's just, we're trying to talk to the schools or something and say, that's not going to fix it.
So there are a number of resources available in terms of just sexual development in individuals with developmental disabilities. There's one particular person, Davida Hartman, who puts out a lot of good educational materials that you can get off Amazon about appropriate discussions and conversations depending on a functioning level. Talking about masturbation. You're not going to stop it. Sorry, it's going to happen. It's natural. It's what's going to happen. But how do we teach the appropriate way to do that and where to do that, when to do that, and depending on functioning level and age. Additionally, I do have a couple other resources I could pass on to the foundation that they could give you the links for those resources. I just sent it out to a family yesterday, so I have it readily available for you. But it is very natural, but it's something we have to teach just like we teach every other skill. Our kids are going to go through that process. They're going to go through those phases, so we need to teach those skills.
There's a follow-up question that just came online for our discussion here. And some of this has already been answered, but I'll ask the whole question. For females with SLO, is there any recommendations or concerns with birth control to assist with periods and other gynecological concerns? Also, when should their first gynecologist exam occur, and can they be sedated for it?
Those are great questions, and they are difficult questions to answer. There's no easy answers. My best recommendation is to actually be involved with a gynecologist. As far as pelvic examination, that's pretty tough. And for our natural history study, if we do have older adolescents, when we do the sedation anyway, we do have our gynecologist do their exam. But counseling, as far as contraceptive methods, is a little more tricky. There are several options available. I talked yesterday about Depo-Provera being a more popular one because it's a shot that you take every 3 months and it does controlled periods. But there are consequences down the line as far as bone density and so those need to be addressed as well. So my best recommendation for that is to actually be in touch with a gynecologist for best options for your child.
Yeah, we use a lot of, in older patients, we use a lot of IUDs because that is, it has to be put in, usually under anesthesia by the GYN doctor. But it's then good for 7 years, and then you don't have to worry about it for a long time.
Just a follow-up question with that, because when our son was younger, people sometimes are very surprised at how, what's great about our children is they love hugs, they love touches, and sometimes they don't, but, in many cases, they love to touch other people or people they like. Everyone is shiny and wonderful, and they'll get excited and touch them or put their arm on them, and trying to get them to not do that is a very difficult thing. You can teach, like instead of, reaching with your hand, do the elbow bump and all of that. But have you ever seen, like Dr. Connor, Dr. Tierney, a sexuality or touch component or in a behavioral plan related to an IEP in a school plan?
It's something for you to make sure they put in there. So regarding that, one of the things that we see a lot is that our kids are treated as if they're much younger, if they have more severe disabilities and they're 16, but they're treated like they're 3 or 4, where you give hugs and you give all these, and it's lovely, but at certain ages, it's not appropriate anymore. And so Dr. Tierney and I were just talking about, you have circles of people who you're really close to, and it's okay to hug mom and dad. It's okay to hug your cousins and things like that. But when you get further and further out in those circles, it's okay then to do elbow bumps, and it's okay to do high fives. But hugging at a certain age and a certain time isn't going to be appropriate anymore. And it's something to have that conversation because our kids are so social. They want that, and it's okay with us. It's not okay with people they don't know that well. And it's hard to teach that, and it's also hard to teach providers where to have that line drawn. But oftentimes I'm the one telling teachers' aides, like, you can't hug him anymore. That's not okay at 13 because he sees it differently than you do,
Oh, I thought you wanted her to go first. Oh, she did. Okay. I'm amazed at how much we've improved in entire area in the last 35 years when my daughter was born. And as a parent, I want to make sure, or I want to impress upon all you young parents to not be afraid to push for your child or to advocate for them, of course. I was so stunned in the beginning, and thank goodness I had two sisters that were nurses, and one of them told me, don't be afraid to, I want you to bark your way up the tree in genetics. Go right to the director, and I did, and that was hard for me. And fortunately, he had, and this is back in 88, and he had just come from a conference in New Orleans, I think, where they were starting to talk about cholesterol with this particular syndrome. And remember, there's nothing on the internet about it. My mother.
Not back then.
There was no internet, right? And I got with him. I had no. He became my case manager. He was very interested in Chandler. He had lots of people looking at her, but I was trying to get in to see this pediatrician that was very well known, and I kept calling the office, and the nurses would say, I'm sorry, this is, wintertime, and we just don't have any openings. The flu's going around, yada, yada, yada. And Dr. Greenberg, the geneticist, met Dr. Thaler in the parking lot of Texas Children's once, and he said, have you contacted this poor Miss Drake? She's just beside herself. And Chandler was very, very ill. And I didn't know what to do with her. And they sent her home at 2 days old and said, try your best to breastfeed her. She had no suck at all. So he was just so embarrassed. And he called me that night and he said, and I love this about a great pediatrician saying, I've never heard of it. I'll be the first to admit it. Never heard of SLO. I'm so sorry that you didn't push to get in to the clinic sooner. You just have to say, look, I got a sick kid, receptionist, and throw out some names. You don't have to be ugly about it, but it's important to just not be afraid to really advocate when you need to. And when I heard you all say that you can make cards and you can share eye chart information across the United States or the world, that's just amazing to me, because we just knew nothing about it back then. So I'm glad I don't want to ever go back to those days, but if I've learned anything, I learned a lot from my sisters who said, you don't have to be a bee about it, just, because you'll get a reputation for being one of those mothers, but I've locked heads with doctors who thought they knew all about this, and Dr. Thaler, the pediatrician, said to me, you're going to teach me. I know nothing about this, and don't be intimidated by them just because they're doctors. You know what I'm saying? When it comes to something like this, you do know more than a lot of them. Maybe not now, but back then.
Very well put.
I had a question about sterilization. She's 15, and the abuse rate is super high, extremely high. And it's a lot of kids are not able to go into the court of law to hold people accountable, the perpetrators. I want to know, with being proactive, is it worthwhile? Is this something that the foundation or you guys as the specialists, do you think advocating for sterilization, if it's good, long-term effects from it, all of that?
I'm going to try. So in my state, in Colorado, it's not an easy process to consider sterilization in a patient with disabilities. Legally, it's extremely difficult to get approval for it. The families and the physicians and so on have to go before an ethics board and have a lot of significant conversation about it, and then it becomes a legal decision also.
What if the child's conserved? Does it matter?
So Things differ state by state in terms of the legalities of it. But people, what's been good in our country, I think, is that we try very hard to protect the rights of all people, no matter whether you're able to communicate and advocate for yourself or not. And that's why some of these laws came into play, to try to protect the rights of everybody, even if you have disabilities, so no one could make, and this is very different from what it was 100 years ago, when people would sterilize prisoners and sterilize people with, in the early part of the 1900s without their consent. We don't ever want to do that. We can't do that anymore. So it's a very detailed conversation and complicated conversation to think about that. Sometimes there are medical indications for surgical procedures. I've had patients with other diseases and severe disabilities where the patient has very severe bleeding, has become severely anemic, and medical medications and things like that have been tried but haven't worked, and then you think about surgical interventions as a last resort. And so I have been in that position, very rarely in the past, but it's not something we ever do routinely. But birth control, yes. Yeah, so there's oral meds, there's Depo-Provera, which is the shot that was mentioned. There's IUDs that last for 7 years. There's other options too. And so the most important thing, as you very appropriately mentioned, is to find a good adolescent GYN physician and talk about what are the safe options for that particular patient.
So I think sterilization is, an ethical issue, and there's going to be a lot of, difficult, probably barriers to that. But this issue would come up all the time when I practice endocrinology, because, it's not just SLOS kids, but, a lot of kids with disabilities. So I think I want to understand from you a little bit better, what would be the purpose? Would it be to prevent pregnancy? So there are other ways, which the IUD is probably the best, and you were right to mention that. Preventing abuse, I'm not sure how you would achieve that with sterilization. Do you know what I mean? It's a very valid concern, but I don't know that you can achieve that with sterilization. So it's a tough question.
Yeah, the other concern is we're fortunate we're in California, but abortion is going to be a big issue in some of the other states. So when this does happen, which the statistics are really high for our kids to get raped, it's crazy. So that's why I worry about other people in other states, especially when they're older.
Absolutely.
Another online question, do other SLOS kids self-play? Since discovery of the screen, there seems to be little interest in other forms of play.
It's not just for SLOS kids.
Yeah. Electronics are the bane of my existence. They're wonderful because, yes, they can be a really cute little babysitter, so you can go potty, right? As a mom, I want to be able to go potty for 5 minutes, let me go. But the screen is a challenge because it's hard to limit their access because it's so intriguing and so motivating. I do a lot with what I call signaled availability. That's what we call it in our field, is letting them know there are times it's going to be available and times it's not going to be available. So basic old red-green board. Red side means red side is it's no longer available. Green side is you have access, and giving them options. Lots of things on that green side other than that tablet that's now going to be on red. Saving that iPad or electronic device for times when you really, really, really need it. Like you really need to take a shower that day. You really need to be on that important call. That might be the times that iPad is readily available and put back on the green side. Otherwise, it's on red until, appropriate behaviors, they've earned it, they've done a great job that day, no tantrums, no whatever. Use it as a really great positive reinforcer, but limit the access other than that to whatever the current pediatric academy says is the right amount of screen time for a child. I can't tell you how many little ones I'm seeing, 2 years old, carrying iPhones, and like, oh my gosh, please give them a toy, something interactive that they're learning from. So, yeah.
So I know it takes quite a bit of time to work with a behavioral psychologist who can help you create a program like that. But we find for example, in our inpatient unit for individuals with severe self-injury, such that the tablet is actually it's a great thing, because we used to have a hard time finding something that would function as a reward, and the tablet is does function like that. So in that case, it has been quite helpful.
Thank you.
Yeah. But that's why I say limiting it to times that it's really needed, so that it does maintain that potency. Otherwise, it loses its reinforcing value if it's accessed all the time.
So a follow-up question on the last conversation. This particular mom says, I have my child on the arm implant, and it's the best. Let me start over. I have my child on the arm implant, and it's been the best thing because her meds affect most of the birth control. So that's a comment from one of the online. For Dr. Elias, yesterday you presented conditions on which colbum were recommendable, where cholesterol levels under 100 milligrams per DL, liver problems with difficulties for nutrition. But will it also be recommended for patients with cholesterol levels under 100 milligrams per DL in general?
So again, what we're hoping to do is have a study where we can really study excuse me, the benefit of colic acid, the indications for it, what's the best dose. And what we worry about a little bit is that everybody's going to jump on the bandwagon and use it, and then we're not going to be able to study it in a proper scientific way. So I have been using it. It's approved by, Colbam is approved by the FDA for Smith-Lemli-Opitz, but I really don't think that everybody with SLO needs it. If the cholesterol is good enough and you can make stress steroids and your nutrition is good and your weight is great and so on, and your cholesterol level is good, then I'm not really sure that Colbam would be that helpful. We're hoping to be able to look at it in very little children, very young babies who have very more severe disease and are having trouble feeding and growing and so on, and have liver problems from the get-go. I think that's a population that I'm hoping it will really be most helpful. We did not study the little kids under the age of 2 in this very small pilot study Dr. Rizzo and I did, but I think that's one patient population that's going to be really important to look at.
No, I agree with everything that Ellen just said as far as the future for colic acid. We don't even know that it really benefits the kids from a clinical point of view. The study we did was designed really to look at a biochemical point of view as far as does it affect cholesterol levels, but also to ask, is it tolerable and is it safe? That was the objective of this study. We did get additional data out of it, but nevertheless, I think that a study like this where everyone is placed on it is a difficult study to interpret as far as the efficacy of it, because we really have to have a gold standard kind of study where we have maybe a placebo group for a period of a few months and then just see whether or not the comparison between the two groups is different enough that we can recommend colic acid. So there's a lot yet to be decided about how we're going to go about the next study.
Next question is, are there any known families that have multiple generations of people with SLOS?
I'm not aware of any, and we're all shaking our heads.
Parent-child, yes, you told us about, right?
Yeah. Again, it comes down to rare autosomal recessive diseases. They tend to show, you don't typically have a family history unless you're in a population where there's a high degree of consanguinity. And I don't even I don't know of any isolates. What's that? Consanguinity. What did I say? Oh, sorry. Where you're related to your partner closely. Cousins, first cousins. And in some parts of the world, that's very acceptable. And then you do see a frequency of these autosomal recessive disorders rise. You can also see this in more isolated populations that form clusters where there weren't a whole lot of people that moved into that area to begin with. And so you'll start to get some increased frequencies. Some of the disorders in the Amish, et cetera, arise because of small populations, or some of the Jewish associated disorders. But SLOS, I'm not aware of any. There's higher carrier frequencies in parts of Europe, but I'm not aware.
No, I'm not aware either. Yes, I told you about this mother and two daughters who were affected, but otherwise I don't know any, more generations affected by SLOS.
I do have one, but they're separate families, but they are cousins. So it was just sort of bad luck coming in that way. Yeah, this is why I have a nurse practitioner, a nurse sit in the room with me. So autosomal recessive, we all have 2 copies of the DHCR7 gene. To have Smith-Lemli-Opitz syndrome, both copies can't work normally. One from your mother, the one from your father, okay? So every child who has Smith-Lemli-Opitz has a change, got one change from their mother, one change from their father, and that's autosomal recessive, okay, the type of inheritance. Being a carrier, mothers and fathers are carriers. It means on one copy of your DHCR7 gene, you have one that doesn't work or doesn't work well, and one that works. That's why you don't have Smith-Lemli-Opitz syndrome.
And then, of course, with every pregnancy, there's a 1 in 4 chance with an autosomal recessive disease, of having another affected child. So I have seen many families that have more than one affected child, and especially in more mildly impacted cases, I have also seen times when the older child was not diagnosed until a younger child was identified as having SLO, and then they go back and they look at the older sibling and make the diagnosis in that sibling too.
Or Dr. Tierney, did you have something to add?
Yeah, I was just going to mention that 1 in 4 chance, it's with every single pregnancy. If you have 3 children, the next one's still going to be 1 in 4 chance.
I was just curious as the origination of it. Do we know what country or what part, where it came from? And is it true that it's originated from inbreeding?
No. Okay. So it's hard to do those studies in the U.S. because we're all mixed up. But early on, the European groups were able to associate given pathological variants with different areas of Northern Europe in general. The common variant, the IVS8-1G to C, I like the old terminology, that's the most common mutation in Smith-Lemli-Opitz syndrome, appears to have a gradient across Northern Europe that goes from the west to the east. Another common variant, the W151X, actually appears to have the opposite gradient, and the last time I had seen a publication on it was thought to have arisen in Poland. The T93M missense mutation, which is the most common missense mutation, and I'll define missense, okay, W151X and the IVS8-1 G to C are null mutations. They knock out the gene completely. It's gone. It doesn't work. The T93M is one misspelling in that protein. The protein is still made. It still works a little bit, but it doesn't work a lot. That one is actually associated with the Mediterranean region, and is higher in frequency in individuals who have inheritance from the Mediterranean. R404C, another one of these missense mutations, a little less frequent than the T93M, may have originated in France. We find it in French-speaking areas of Canada, and guess what? It shows up in Louisiana. So these things have been in generations and generations. I don't think anybody has, those studies were done by the Austrian group early on. I don't think anybody has really pursued, defining those geographical patterns. But yeah, some of them we do know where they likely arose from.
So to follow up that question, I missed a minute and I had to take Lexi upstairs, but is there research on like what each mutation, kind of how each mutation presents? Like you just mentioned, we know there's a couple of them that are null, right? So my kids each have that. I have 2 out of my 3 that have SLO. And then the other one they have is the S169L, which I don't think is super common. I know of a couple of other kids that have it. But I didn't know if there was any research that showed kind of these mutations result, or this combination of mutations result in kind of this laundry list of issues or not.
Yeah, very good question, and it'll keep my lab busy for a while. So what you're getting at is, as a geneticist, the holy grail of a genotype-phenotype correlation. Okay? They're generalities. If you have 2 of those null mutations, that's not good. Okay? T93M in general tends to be milder, but there's all kinds of variation. And this is true of all these autosomal recessive disorders. You have 20,000 other genes that are all impacting. And they can influence an individual. So where we can talk about generalities, it comes with large error bars for it. I'll flip back to my other hat. So we have mouse models. I could put the mouse model on one mouse background, and it lives. I can put the same Smith-Lemli-Opitz genes on another mouse strain. It dies. And they're the same exact DHCR7 mutations. So, how we get at those genetic modifiers, I think they're important, one, to help parents understand. But identifying them in rare diseases is not easy, but they may provide insights in maybe how we can modulate or what therapies, But you've got lots of other genes that interact. If you have a real robust antioxidant system, you might be doing better than somebody whose genetic background is not as good in that respect. Oh, I'm a geneticist. Okay, yes. Environment impacts, and yeah, I just don't study that part of it. Yeah.
So I just have one more question. My oldest is 16, and the first conference that we went to was when she was 2, was the first one after she was diagnosed. And I know, a lot of information has been gained since that time. And I know, when Lexi was first diagnosed, it was like, oh, there's no, independent, individuals that are living independently. I think it was Dr. Rizzo maybe that mentioned like, now we're maybe starting to diagnose individuals that are older, that were missed. Maybe they're mild or moderate or something that it was missed when they were younger. So I was just curious, like, is there any more information now about, kind of maybe individuals that are on the milder end of the spectrum, for lack of a better word, being able to be more independent or that sort of thing. I know that my 16-year-old's a little bit more affected is the right way to say it than my 8-year-old. But I'm just curious because she's starting to ask questions, and I'm just like, oh, you're going to live with mommy forever, but like, obviously I want to be able to offer her options as well. We're starting to kind of give her a little bit of independence as we can. Just send her upstairs, and she's going to be fine for a little bit. But I was just curious, kind of, is there more information now than there was, 14 years ago when they're like, oh, if they have this, they're always going to live with you, or there's going to be little that they can do.
Let me pass it to Samara, who's actually been trying, because it's a very good question.
Yeah, it's an excellent question. We get asked that a lot, and that's one of the goals of our natural history study that I shared yesterday. We are trying to answer that. So of the 16 individuals I have so far that we've done this medical history taking with who are above 16 years of age. That's one of our major questions, which is, is your child able to feed themselves, dress themselves, do personal hygiene? I would say at this point, about 70% needed some degree of help, but again, to very varying degrees. So some would need everything done for them, and others, if you lay out the clothes, they can dress themselves. If you make the sandwich, they can feed themselves. So I think there's a variation, just like everything with SLOS. But, it's, again, I think we go back to one of those things you can work on teaching, and depending on your child, you can make a lot of strides with that. But there is hope. I mean, when I say 70% needed some degree of help, 30% didn't. So it's not like it's universal. So, but this is the information we're trying to collect. So, yeah.
We have time for one more remote question before we take a break.
Okay. And mention breakfast is served for another 10 minutes. So if you want to go grab breakfast because we have such a long line, then do so. And and for those online especially, there are about 13 or 14 more questions. Obviously, we're not going to get them today. So we'll get them to the advisory board, and they'll be answered over the next few weeks, so just so you know. Last question. Do you consider, and I know we've talked about this a little bit in the last few minutes, but do you consider heterozygous carriers of zero mutation, the W151X and the IVS8-1G to C in your research, taking into account that these patients have 7-DHC reduced expression to cholesterol by 50%, and SLOS patients have it reduced by 55 to 65%. In both cases, 7-DHC oxides into oxysterol, which causes the main problems. According to the records by Living Zhu and Alexander Soft, oxysterol negatively impacts neurogenesis and membrane.
Yeah, I'm not sure we understand the question.
We can, what we should do is we'll send that one, and then you can look at it, because I'm not sure we completely understand it just based on our knowledge, and so we'll send that one.
And so last question, have you seen children with laryngeal clefts? That was asked a couple times yesterday. Has anyone, laryngeal clefts?
The microphone?
No, sorry. A cleft palate is much more common. It's up in the roof of the mouth. But there sometimes can be clefts further down the airway, and the larynx would be a laryngeal cleft. It's not a common defect in SLO, but I have personally not seen it in any of my patients. But like everything else, that's not a totally rare defect and could be seen.
Thank you so much. Let's give our physicians a warm round of applause.
Your contact information, you're all a part of our foundation, or will be in the future. Your contact information is on our website. How comfortable should our families be to contact you or have their physicians contact you directly? Can we use it?
Yes.
Anytime they say.
Is that even for international folks?
Sure.
Yeah, sure.
Email.
Wonderful. Thank you so much, and we'll take a small break. And Andy, you want to give any instructions?
Yeah, we'll be back at 10:30, and I think at that point, Gretchen will reintroduce Denny Porter and talk about SLOS research and legacy tissue donations. So go rush the omelet table, and we'll see you in 10 minutes.